another key component of the records is the master cast and the bite registrations and all the little details about this. So we can make this really hard, we can make it easy. A lot of these cases are very challenging, so you know, some of these bites are going to be a challenge. We're going to go through some situations. I think I can really share some good information for the bite registration. But just remember that you can take digital, you can take analog. Today's digital impression scanners will, I mean, just about all of them will scan a full arch perfectly. I was scanning yesterday with the Trio scanner, the brand new one, and I scanned a complete denture with the shiny palette in about 1.5 minutes. I've never seen anything like it. It scanned it so incredibly fast, and it will scan the entire soft palate tissue area with vibrating line in under 2 minutes perfectly. So we highly recommend digital impressions. We just noticed that we get better borders, we get more accurate impressions with digital. So, and that's about 60 to 65% of our cases today. So a lot of them come in analog, perfectly fine, no problem. Alginate, PVS, you decide, just capture all the land areas. Make a custom tray, capture the land areas. You want the hand-meter notch, the retromolar pad, you want the periphery, you want the borders, you want everything. So, and the reason is because the models have to be brought into our software using landmarks. We need those landmarks very clear. We need lots of them to merge with the DICOM. And we also need to fabricate a pin guide for the first seating, for the initial part of the surgery. So if you see in your impression or your digital or in your cast, a blurb, a pull, a hole, a drag, a lot of those things can be fixed. They can be burred. We do it all the time, been doing it forever. But just remember that on the day of surgery, the pin guide is only gonna fit as good as the record. It's the only way for us to make a pin guide. It has to be from your STL file or your master cast. So take great care with the master casts. So let's go through the bites because really everybody can take lovely casts and lovely impressions. But the tricky part is the bite, and then deciding if you're going to take a centric bite or if you're going to take a centric occlusion or a centric relation bite. One of the tools that we use, we use many when we're analyzing these cases clinically or in the laboratory, is the Shimbashi measurement. This is something that can be easily accomplished chairside, and I'm going to go through many cases of where you can take this measurement and really guide us as far as the bite and opening, based on your records. So Shimbashi, Henry Shimbashi, years ago analyzed 500 patients and determined that a patient with good occlusion, good function, good vertical, good smile, all these different attributes, the measurement from the gingival zenith of an upper central to a lower central was about 19 millimeters plus or minus 1. That's ideal. Now we find that compromised patients over the years are somewhere between 17 and 21. So a little bit more of a variation. Tough to get these perfect because they started somewhere and here they are now closed. So somewhere between 17 and 21 gets us in a nice position for smile, jaw, condylar, muscular, space for prosthetics, etc. If you can get us to 19 or around there, we're gonna do really well with the case. So bear with me while I go through about 10 different situations where patients walk in the door. So the first one, pretty straightforward, right? Patient has a lot of centric stops. They have repeatable occlusion. This patient is going to bite in this position every single time. That's your bite. That's your centric. So in a case like this, if you want to, you could take a measurement of that gingival zenith. You can see it's tough here. The patient has recession on the lower, but you can always draw a line from right around the canine to canine and find some line in here, right around the CEJ, right here. or perhaps a little bit lower because this could be a little super eruption. I don't want to get too complicated and technical here, but this patient is about 18. So upper and lower impressions and a nice centric bite. You can, with a patient like this, you can just load up the entire arch with bite material and send it off. This situation is also very common. Patient has a partial denture and the patient is having a maxillary chrome surgery, which means that the pin guide has to seat on the patient's natural teeth, not on the partial. So in this case, this patient they do have enough centric stops. They have a lot of remaining teeth. They repeat their bite. But what we really need is we need a couple of different impressions. The lower, this is just an upper. So with the lower, you would take an impression. If they were wearing a partial, then take a study model with the partial seated. That's our occlusion on the lower. That's our tooth position on the lower. On the upper, you would take a study model with the partial seated, and then you would take another, forgive me. I have a couple of cases in here that are very similar. In this case, it would really be optional if you want to send a study model along with the upper. This patient still has 8, still has 10. We can design an arch form. We'll probably have to open the bite because of the class 3. But this could be just an impression of the upper without the study model. Study model optional. If you really want to share with us where number 9 is, take it. Otherwise, upper, lower PVS bite. All right. Patient's about 17 millimeters. That will do for the initial record, because you'll notice on our work authorization, which we're going to go through later, is that we've added an option that we can open the bite 4 millimeters without calling. That will help tremendously with cutting down the number of phone calls that we have to make. We can open this bite up, and we can do this very comfortably with all those centric stops. So even though 17 is at a minimum, really, when you're doing a chair side evaluation, we can open this case up to 21 if we need to, by your approval. Okay, very, very common, challenging situation. Patients deep class 2, the lower teeth are in the gums, which means no good centric stops, no repeatable bite. Kind of guessing there, but that's kind of what you see. This patient can bite in many different areas. Maybe you would see a stop right here, but there's no stops on the other side. So no good centric position. So that means we need to establish and restore the patient's vertical dimension. So yes, we call it opening the bite. That's going to be the common, the lingo, the jargon, but really we want to restore this patient's vertical dimension. So on this patient, this would be full land areas, all the anatomy, upper and lower impressions, cast, bites, digital, whichever you want. But the bite registration, this is going to be a little bit different, because you can have 2 options. One is to capture the patient in the existing centric closed class 2, which means we're going to take a patient on the articulator from 7 all the way up to 17, 18. It's a big opening. We don't want to do that on the articulator and then go to surgery. We'd have to do a try-in, and I'll show you what that means. That's one option. Centric bite, ROE Dental Lab opens the bite. Happens all the time. We could do something a little bit more expeditiously, which would be, you could make bite blocks. Bite blocks are not the most predictable, stable way of doing it, but you could also do a setup, lock the patient into that new vertical dimension, capture that bite registration, send it in with the models. That would be perfectly fine. In this case, there just aren't enough leaf gauges to open up the patient 10 millimeters. So probably bite block, work things out with try-ins on your own, or with us making your bite blocks and trying. That'd be fine. A little back and forth, test it, put the patient in a flipper, let them wear it for a while, test the bite. Nice option. Another option would be to send us centric. We make you JC try-ins. We open the bite on the articulator, and then you try these in and you go through a process of equilibration. We'll talk about that after these examples. This is a double arch chrome case. Patient only has about 9 millimeters of a Shimbashi measurement. CEJ to CEJ. Patient is severely closed. No good centric stops, no repeatable bite. So what do you do? How do you send this to the laboratory? Well, again, this would be upper lower cast, and then make a decision on what type of bite you want to send to us. In a case like this, could send centric, row can open it, do JC trions, just like before. Another option would be neuromuscular bite. Could be, you can't really do a Dawson bite because you're not going to have a first point of contact. So you have to find some other way to find a centric relation bite. Could be leaf gauges. Could be through a little bit of speech and splint therapy. There's different ways of doing it. Always recommend working that out first before the records come in. Those things take a lot, they take a lot longer time for the patient. And most of the time we want to get these cases done pretty quickly. So something like this, centric bite, row opens the bite for you about 6, 7, 8, 9 millimeters. And we make some judgment calls based on photographs and a need for materials and and bone reduction. Send you JC trions and confirm them. And again, we'll talk about the JC trion. Another common situation here, really tough to get a Shimbashi measurement. Patient has bone loss, teeth missing, that kind of thing. Tough to go by. So this kind of case, the patient hits and slides, right? So no good positive centric stop. So on this case, same as always, nice upper and lower casts, but you got to decide now when to take the bite. Now, normally in a hit and slide, that means the centric stop is the first stop. The slide is relation. The first hit is centric occlusion. So U is centric. So practice with the patient, have them hit without the slide. And then you can even do a little mark on the nose and the chin. If they're really doing a slide, most of the time they're not sliding too much. They're just sliding a millimeter or so. Have them stop in the hit, and then while the patient holds it there, backfill the gaps with impression material. That's your centric bite. That's our starting point. That's a very nice way to take a hit and slide patient. And you'll identify them. You'll know. You'll practice with them, and you'll see them closing as they go. Another, I guess I'm going to say all these are common because we see so many cases here at the laboratory. This is a common difficult one because the patient has no centric stops, but they're also free end. All right, so you can't just load the posterior full of material and try to capture this because the patient is going to bite, they're going to close, they're going to slide, their condyle is going to move. There's all kinds of things that can happen when you're trying to capture a bite on this patient. So this one, this is going to be an upper lower. You'll capture a bite as good as you can with the existing teeth. And then this is either bite blocks or a JC trion. For us, we almost always lead towards JC trions because they're a solid stop. They're adjustable. You can do a blue moose reline. Well, we'll go through the JC trion in just a minute. But it's a nice hard stop as opposed to bite blocks. We go about 17 on this patient, maxillary chrome, 17 will work. Probably would leave the patient in this position. You can see in those the lower images that we would only need to maybe open the bite a millimeter and then try to create some occlusion where the patient's not having interferences when they're going into protrusive. So this would be upper lower bite, capture the upper teeth in the bite registration. The patient has no posterior occlusion. So JC trion. So that's why a lot of these cases are not 20 days, 18 days, 20 days. They're a little bit more because we have to confirm the bites so we can go to surgery predictably. This is a case, super erupted lower or patients just closed down. There's always arguments of whether it's super eruption or whether it's just, just a loss of vertical. In this case here, this would be good centric stops. Patient has lots of posterior occlusion. The depth of field on this camera doesn't show very well, but patient has a repeatable bite. In this case, this would be upper lower nice bite, good solid stops. And then Roe and the doctors, we're going to have to decide what combination of bone reduction and opening are going to be suitable. Patient's going to have to be opened a little bit, and then probably considerable bone reduction. But I just see these kinds of cases pretty frequently.